Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. Are you concerned about skin cancer or any other skin condition? Find out more right now. My guest this evening is Dr. Maria Sotomayor, a noted dermatologist practicing right here in Montgomery County. Dr. Sotomayor, welcome to Housecall.
Thank you for having me.
My pleasure. Briefly tell our viewers about your professional background and education.
Went to medical school in Lima, Peru. I graduated and immigrated to the United States.
Okay.
Worked in research and did my training in dermatology and University of South Florida in Tampa.
Uh-huh.
And I practiced for 16 years in Tampa in a private practice.
Yeah.
3 years ago, moved to Washington, and I work as an assistant professor in the Department of Dermatology at George Washington University. And recently, in the past 3 months, I started working at Arundel Dermatology in the office in Rock Creek in Silver Spring,
Very nice.
Maryland.
Briefly tell our viewers what exactly is the field of dermatology?
Well, dermatology is, as you know, the skin is the largest organ in our body. So I always tell my patients, you really need to learn how to take care of your skin, and the skin can be an organ that can manifest internal problems. Some diseases show up first in the skin before they show up in other organs. So as dermatologists, we have training. Our basic training is at the first year in internal medicine, and I think it's very important because we need to be involved in all conditions affecting the body. Mm-hmm. And then we do 3 years of dermatology, basically clinical dermatology, but we also do train in surgery, dermatology surgery. After completing the 3 years of dermatology training, you can opt to do like a fellowship in cosmetic, or Mohs type of surgery, or pathology, contact dermatitis, and there's, mainly it's a broad kind of specialty.
Sure. But your practice in Montgomery County is general dermatology at this point?
Yes, it's mainly general dermatology and dermatology surgery.
All right. Let's go on then to discuss a very important topic to our viewers, and that is skin cancer. First of all, what are the risk factors for developing skin cancer?
Well, risk factors, first thing I will mention is that anybody can get skin cancer.
Okay.
It doesn't matter the color of your skin. Of course, we know that people with fair skin, blue eyes, blonde hair, have a higher risk of developing skin cancer, but it also counts the amount of sun exposure over the years. And we know now that the continuous exposure accumulates the damage in the skin. And eventually, some people can start developing skin cancers, usually in their 40s, 50s. But recently, we're seeing an increased number of women younger than 40 years of age developing skin cancer.
You mentioned the classic fair-skinned individual being at higher risk for skin cancer.
Correct.
As you know, there is a misconception in the African American community.
Correct.
That they cannot get skin cancer, including the most serious type, malignant melanoma, which we'll touch upon shortly. Would you please clarify the misconception for our viewers about African Americans and skin cancer?
Yes, as you said, there is a misconception. Most people with skin of color, African Americans, Hispanics, they grow up thinking that because they have darker skin, they do not need to protect their skin from sun exposure. So they don't apply sunscreen, they spend a long time outdoors, but there's a risk of a skin cancer, less than fair-skinned people, but still they develop skin cancer, and they can develop skin cancers in places that have never seen the sun. They can develop skin cancers like in the palms of the hands, soles of feet, the genital area, places that they don't realize, they don't look at. And unfortunately, in that population, most of the times when we diagnose skin cancers, it's in advanced stages.
So is it correct that if you're African American, for example, and develop a cancer like malignant melanoma, it may be more aggressive than in other ethnic groups?
Yes.
Okay.
It's usually diagnosed in more advanced stages because that population don't look at their skin. They're not educated in preventing skin cancers. So they don't see the skin or check for any changing moles or new lesions. So once a lesion in the skin starts bleeding or itching, that's when they look for primary care that refers the patient to a dermatologist. And when we do biopsies, they're usually advanced.
Do you think it's more advanced because of delay of diagnosis or because it biologically grows more aggressively in African Americans?
It's mainly because of delay of the diagnosis and because of the locations that usually appears that, of course, they're not accessible to self-skin exams. Like, we usually don't look at the soles of our feet or in between our toes. It's not like something we see all the time.
Right. You mentioned several times already prevention. So our viewers are wondering, great, what can they do to prevent developing skin cancer?
Well, it's well established now that sun exposure over the years is a risk factor to develop skin cancer. So the main target as dermatologists to educate the population how to prevent sunburning early in life. We know that most of the damage is from the sun is made before we're age 18. So preventing sunburning by protecting the skin from with the sunscreen since early age. And it's not just applying the sunscreen, you have to learn how to apply it. We recommend as dermatologists sunscreen with broad spectrum. That means that it will protect from the UVA and UVB rays, also with a minimum sun protection factor or SPF of 30. And the key is to apply the sunscreen before you get outdoors, maybe 10-15 minutes, and reapply it. One application doesn't last for more than 2 hours, or if you get in the water or you sweat a lot, it's recommended to reapply it. So good sun protection is the key to prevent the skin cancer in the future.
Besides wearing sunblock, are there any other things that could be done to reduce the risk of skin cancer?
Protective clothing, long sleeves as much as possible, wide brim hats, sunglasses, and trying to seek the shade. We know that the UV rays are more intense in the morning and early afternoon, between 10 in the morning and 2 o'clock in the afternoon. So try to avoid direct sun exposure during those hours. It's important.
Do you think patients, regardless of their history of sun exposure, should get an annual total skin exam?
There's no definite guidelines when you should start having a skin exam by a dermatologist. Many primary care doctors, even pediatricians, they offer skin exams as part of their routine checkups. But of course, if you have a history in your family of a skin cancer or fair skin, history of sunburns, and you have been exposed to not necessarily sun, but even people with low immunity, organ transplant patients can get a skin cancer. So after, I would say, age 40, it's recommended to have an annual skin exam.
And it should be a total skin exam.
A total body skin exam. And we educate the patient also how to check their own skin. The American Academy of Dermatology have good website that has like a body mole map, so the patients can follow and check their moles, so it's easier to keep track and monitor for changes in moles.
I understand in the field of dermatology there is an expression, the ABCDEs. What does that refer to?
Well, it's referred to the ABCDE of melanoma.
Okay.
As we know, melanoma is the deadliest type of skin cancer. So to make things simple, we're trying to educate the population. And A stands for asymmetry. If you see a mole that you cut in half, the two parts look different, that's a suspicious sign for melanoma. B is for borders, irregular borders. They don't have the well-defined borders as a normal mole. C is for color, different shades of color. Not necessarily dark brown, it could be reddish, purplish, dark brown. And D is for diameter. Usually we point out like the tip of a pencil eraser, which is 6 millimeters, but recently, the Academy of Dermatology added the E for evolving because there are smaller moles that can change over time. So that's why it's important to start checking the skin at home ourselves and try to follow those guidelines to see if any of the moles looking a little bit different, you should, of course, see a dermatologist.
And of course, the dermatologist would be best qualified to tell you which skin lesions you can ignore and which need to be biopsied or even removed.
Exactly, because we're trained, we see these type of lesions all the time, and we also have a special instrument called dermatoscope that in the last 10 years has been developed, and that helps us to magnify and light up the lesions, and we follow some patterns that can make us suspicious that that particular mole can be worrisome for a melanoma or a skin cancer. So that's when we decide to biopsy, because it's impossible to biopsy all moles in your body. There are people that have tons of moles and they all may look a little bit different.
Sure. We have 1 minute left before we go to the break. Malignant melanoma, as you know, is the most aggressive form of skin cancer.
Correct.
Tell our viewers very briefly how it can spread throughout the body.
Well, the melanoma usually can be in the surface, and if it's removed and treated on time, 90% of the times it's cured. When the melanoma is diagnosed and it has been bleeding, or it's when we do a biopsy, it's deeper, so it compromises the second layer of the skin. We call it invasive. It can spread first to the lymph nodes. That's why when we send the patients for surgery, the surgeon also checks for spreading the melanoma to the lymph nodes. From the lymph nodes, it can spread to many organs, mainly the brain, the liver, bone, and the gastrointestinal tract too.
I'm going to ask you to hold the thought there. We're going to pause for the break. More with our guest, Dermatologist Dr. MariaSotomayor. We'll be right back.
150 over 90.
180 over 111.
160 over 110. I had a stroke.
This is what high blood pressure looks like. You might not feel its symptoms, but the results from a stroke are far from invisible or silent. If you've come off your treatment plan, get back on it or talk with your doctor to create an exercise, diet, and medication plan that works for you. Go to loweryourhbp.org.
If I would have followed a treatment plan, I would not be in this situation.
We're back. My guest this evening is Dr. Maria Sotomayor, and we're discussing topics in skin health, dermatology. Dr. Sotomayor, when we paused for the break, we were discussing the most serious form of skin cancer, malignant melanoma, and you pointed out that when caught late, it can spread throughout the body to many organ systems, including the lungs, the GI tract, the liver, which of course is of interest to me, the brain. It can be life-threatening. Unfortunately, former President Jimmy Carter has developed metastatic malignant melanoma and reported it several years ago that it even had spread to his brain. And happily, he's been the beneficiary of some new therapy that apparently has allowed his cancer to disappear and go into remission. Clearly, there's a lot of exciting new therapy that's out there for malignant melanoma when advanced, when it's metastatic.
Exactly.
Share with our viewers what's going on there with President Carter and other similar patients.
Well, in the last 10 years, there have been tremendous development of new immunotherapy treatments. That means those are treatments that will target different pathways in the tumor development. So first they started with some of the drugs, but now they keep developing new ones to combine.
Right.
And there are many patients now, as you mentioned, President Carter, that can survive, and they, of course, need to continue monitoring, but it's an amazing field now, immunotherapy, which involves a field of oncology and dermatology.
Very interesting. Now, of course, besides the most serious type, malignant melanoma, there are other types of skin cancer, though of significance, are not quite as aggressive, not quite as potentially life-threatening. Share with our viewers some other categories of skin cancer.
Well, the most common type of skin cancer is called basal cell carcinoma, which is a cancer of the basal cells, which are in the bottom of the first layer of the skin. And this, of course, type of cancer appears more commonly in sun-exposed areas. We see it commonly appearing as probably around age 40 and older, but we're recently seeing more younger, especially women, developing this type of skin cancer. The second most common type of skin cancer is called a squamous cell carcinoma, which is a type of skin cancer of the cells within the first layer of the skin. And this type of skin cancer is also triggered by sun exposure for a long period of time. We have like precancerous lesion of this type of squamous cell carcinoma called actinic keratosis, which are flaky pink rough spots that we see mainly in people over 40 years of age that have been exposed to the sun for many, many years. And these two types of skin cancer, the basal cell and squamous cells, we call it non-melanoma skin cancers, which are the ones that we can treat mainly with surgery. If they are superficial, there are treatments with creams, scraping, or even spraying liquid nitrogen. So they're mainly, they can be cured.
Yeah. Now, actinic keratosis, since that's a potential precancerous lesion, when you observe that on one of your patients, do you just continue to follow it, or do you preemptively remove it?
We usually treat it because even though not all of the actinic keratosis precancerous lesions turn into the squamous cell, we don't know which ones will. So we treat the actinic keratosis. So main treatment is to spray liquid nitrogen, which burns and freezes, and the lesions peel off. Sometimes, especially on the scalp, they appear thick, we biopsy and remove and curettage. But we don't try to leave those lesions without treatments. If the patient has multiple lesions, like on the scalp, on the face, there's also treatments with creams, fluorouracil, and even the photodynamic therapy, like it's a blue light treatment to remove this type of precancers.
You mentioned earlier during the interview family history. Is it the sense in the dermatology community that there is a familial, a genetic risk for developing skin cancer?
Yes. Well, as I tell my patients, you inherit from your family the color of your skin, the color of your eyes, so there's predisposition, of course, to develop skin cancers if you are exposed to the sun without protection. But there's also some genes that can be passed or can run in families. There's some, especially for melanoma. And these type of genes not only increase the risk of melanoma, but there are other cancers like pancreatic cancer, breast cancers. So that's why in cancer centers, there's some clinics that the patients can be having a skin exam if they have this type of genes, like genes that increase the risk of breast cancer. Patients come to also have a skin exam once a year as a prevention.
Now, there is a certain skin cancer that you can treat with a procedure called the Mohs procedure.
Correct.
Explain to our viewers what exactly is the Mohs procedure and when do you utilize it?
The Mohs stands for a micrographic surgery, and it's a type of surgery that we recommend, especially for basal cells, squamous cells, some melanomas, but in locations that have a high risk of recurrence, like the face, the scalp, the ears, or if the skin cancer is larger than 2 centimeters, it's better to have the Mohs surgery. And that implies to remove the skin around the biopsy scar. And while the patient waits, the tissue is examined under the microscope. The surgeon, of course, put a mark, and depending if there is an area that still contains the skin cancer, they have to go back and cut more from that area. So sometimes a little pimple type of bump on the nose that we diagnose, and it's a basal cell type of skin cancer, we send it to the Mohs surgeon, which is just a dermatologist that specializes in this type of surgery, could end up having a big excision with a big scar, because the more the surgeon sees in the histology, you have to keep removing.
It may require some reconstruction then.
Exactly, yes.
Yeah.
Sometimes they send it to the plastic surgeons for reconstruction.
Right. Now, there are many viewers out there that unfortunately may have already had unrelated cancers and received chemotherapy. Or other patients out there that have what we call autoimmune conditions, such as Crohn's disease or ulcerative colitis that I treat, or rheumatoid arthritis that rheumatologists treat. And in those categories, they get what's called biologic agents to suppress their immunity to get them well, whereas patients with cancer will get chemotherapy. There is a growing sense that if patients have received chemotherapy for cancer, or any of these biologic agents for immune disorders, that there may be a higher risk of developing skin cancer.
Correct.
So is that something the dermatology community agrees with? And,
yes.
And what kind of frequency of total body skin exams do you recommend?
Well, we recommend at least once a year, but if the patient already had a skin cancer or a high risk in the family of a skin cancer, we recommend twice a year to have a skin exam. We also educate the patient how to check their skin at home themselves, because that's very important.
So even if somebody's had cancer and been successfully treated and received chemo and they're no longer on chemo, you still would recommend this as a preventative measure?
Yes, correct.
Okay. Well, why don't we briefly shift gears to discuss cosmetic dermatology? What exactly is that?
Well, it's a specialty in the dermatology field. Most dermatologists are trained in the cosmetic field with basic cosmetic procedures. Some are trained in lasers, lasers to remove hair, to improve the appearance of the skin. There are different types of lasers, of course. There's also cosmetic procedures to reduce wrinkles, like Botox or other injectables. Also fillers to reduce the saggy skin. And there's microneedling. There's many different cosmetic procedures now that it's like an open door to many possibilities. But during our residency program now, the dermatologists receive training.
How do you choose between each of those options?
Well, it depends on the type of skin. It depends on, it's usually female that seek cosmetic treatments, depending on the age and the type of skin. We recommend Botox to smooth the muscles if they're more concerned about wrinkles on the forehead, the crow's feet. Fillers are more to fill up gaps like around this area, cheeks. For rejuvenation of the skin, lasers are important. Of course, more treatments, and some people are more concerned about laser removal, hair removal. So,
and each of these options, Botox, for example, or fillers, how long does that benefit last?
well, Botox usually 3 months up to 5 months, because it interacts with the nerves and relaxes the muscles, but over time the muscle regains the strength. You don't produce wrinkles because you basically move your muscles as you're used to. But fillers, because they are substances that hyaluronic acid that are deposited in the skin, they can last from 9 months to a year. There are now some fillers that can last for 2 years.
Very nice. So, Dr. Sotomayor, if our viewers have any questions, how can they reach you?
Well, we have a website, Arundel.com, and a phone number that I would provide.
All right. Well, thank you for joining us on Housecall.
Thank you very much for having me. It was a pleasure.
My thanks to Dr. Sotomayor. My thanks to my terrific team here at the station. And thanks to you for welcoming us into your home. Tell us how we're doing. You can reach me at my practice website, MontgomeryGastro.com. As for our next show, it's going to be an important one. Dr. Martha White, a noted allergist here in Montgomery County, will be discussing hay fever, asthma, and food allergies. It's going to be a fascinating show. See you then next time for another edition of Housecall. Good evening.